Hello, everyone, and welcome to another audio podcast in this series, the LabTronix series. And this is another RPSG and KDOS collaborative, and it's part of the Ballistix Edition. And today, I'm going to provide an overview in this audio podcast around renal and primary care. And this is going to be part of, as always, as part of the Storm Robotics production. And once again, it's the Scientist. So in context of primary care, primary care is recognized to have an important role in identifying and managing CKD patients, and there's work going back to 2012 and sort of and also more retrospectively, but since 2006 primary care has been sort of remunerated for maintaining sort of a register and providing evidence-based care for individuals, in particular in between acute kidney injury, AKI, but also in regards to CKD stages, more specifically around CKD stages 3 through 5. And again, there's work that's been evidenced in works by Blakeman and team in 2012. And there is evidence that a large proportion of people or individuals with CKD are undiagnosed and can go undiagnosed, and the management generally between health sectors can be, unfortunately, and at times can be suboptimal, with evidence that practitioners do not currently accept or always implement, for example, the national guidelines according to the National Institute for Health and Care Excellence, or NICE. And again, there are works that have been highlighted by Blakeman and team in this regard. Primary care generally has a range, sort of is generally where there's a range of concerns that can be raised by GPs or general practitioners, including, for example, having difficulties associated with assigning a diagnosis, and in context of assigning diagnoses, it's where physicians or GPs or general practitioners generally, according to what is referred to as quality outcomes frameworks, or QOFs, are as part of their sort of practice in primary care. One of the challenges has been where, in context of coding patients against, for example, particular stages of chronic kidney disease, where there's classification and severity. There has been historically there has been sort of challenges in some regard in relating to assigning a diagnosis, and primary care generally has had issues around that. But since for example, in the last decade, so since 2009, 2010, in primary care teams, assigning a diagnosis, it has become a bit more sort of a bit more of an approachable sort of effort. And there's also the stigmatizing effect of a diagnosis. There's also the explaining the concept of CKD to patients. There's also from a link between laboratory medicine and primary care, is where there can be issues in achieving particular targets in context of, for example, in context of blood pressure, and also where patients in chronic kidney disease may have issues with particular medications, and for example, so there can be complicated medication regimens as well, and also in between healthcare sectors, there can be, or has historically, there's been some research to highlight for example, there's been challenges in context in relating to referral from primary care to secondary care as well. However, that being said, there have been some guidelines as well. So the introduction of guidelines for the management of CKD requires a considerable change in sort of attitude and behavior by primary care clinicians. And again, works by Blakeman sort of highlight this. And changing the professional sort of behavior is recognized as can be recognized, or has been recognized in some contexts, as difficult, and addressing the implementation gap requires an understanding of the reasons why resistance to change and facilitators of change. And so this then follows for example, the question, how is chronic kidney disease classified? How is it classified? So CKD again is divided into 5 different stages based on estimated glomerular filtration rate according to the Kidney Disease Outcomes Framework, Kidney Disease Outcomes Quality Initiative, or the KDOQI classification, and a minimum of 2 eGFR estimated glomerular filtration rate values, at least at 3 months, should be used to diagnose and classify CKD. Now, in this context, just to add, for example, in this context, generally speaking, where patients are followed up in between sectors in some regard, but in context of classification and severity around chronic kidney disease, generally speaking, historically there's been guidelines that have been followed in and around the KDOQI guidelines. And again, in one of the previous slides, I did mention, for example, the NICE guidelines, the National Institute of Care Excellence. Generally, there can be conflicting sort of context between the guidelines, in context of how primary care physicians or general practitioners implement aspects of coding in a line to how patients are diagnosed, and so therefore, generally speaking, it's down to where patients have tests and investigations in and around laboratory medicine, and also down to the sort of intuitiveness or the initiative around, for example, primary care physicians and general practitioners, and those who know about chronic kidney disease to ensure that the appropriate diagnosis is timely. So temporary rises in creatinine, for example, are common, and a diagnosis of progressive chronic kidney disease should only really be based on a sustained decline in renal function. So if, for example, a patient in primary care is on, for example, over several time points, where there's consistency in a renal decline or renal insufficiency, and that's been evidenced, at that point is basically where the GP, the general practitioner, or the primary care physician should seek to refer the patient or the individual into secondary care, where they can be appropriately followed up into ensuring that they are prepared for a form of renal replacement therapy. And in this context, it could be, for example, peritoneal dialysis, or it could be hemodialysis. So generally, how in context of the question, how is a CKD classified? Generally, again, there's five stages of chronic kidney disease, or CKD, but generally the coding of patients against particular classifications are where some general practitioners and health professionals in primary care can have challenges because of the sort of where there can be conflicts between different guidelines and different aspects of practice. Now, in context, and also in related context, in estimated glomerular filtration rate, so the most widely used, or the most broadly used measures of glomerular filtration rate has been to implement the use of the biomarker serum creatinine concentration, or creatinine clearance, calculated from the amount of creatinine in a 24-hour urine collection and a single measurement during this time of blood creatinine. And there's works dating back from 2007 that sort of highlight some of this in regards to EGFR. And creatinine clearance sort of tends to overestimate, and I want to emphasize this again, that it tends to overestimate glomerular filtration rate in context of renal function, because creatinine is secreted by tubules and filtered by the glomerulus, and there can be a difference between the way the tubules and the glomerulus, specifically from an anatomical perspective, function. So measurement of creatinine clearance involves timed collections of urine, and so is and now, in context of today's sort of nephrology practice, for example, is where even nephrologists now, along with sort of biochemistry teams in pathology, for example, still warrant where they require urine specimens to detect to help detect sort of measurements in creatinine, along with obviously blood samples as well. I'm going to talk a little bit about improving global outcomes. So in context of the KDIGO, and so KDIGO has defined CKD, as renal damage or kidney damage, wherein the glomerular filtration rate is less than 60 mL per min for 3 months or more. Now, renal damage can be ascertained by the presence of albuminuria, which can be detected by urinalysis and confirmed by finding or identifying albumin to creatinine ratio, or PCR, or protein to creatinine ratio, PCR, or albumin to creatinine ratio, or ACR. And generally, where there can be more than 30 milligrams for example, of protein that's leaked into urine, in for example two of 3 spot urine specimens. And again, there's works that's been highlighted in 2007 in relating to this. Kidney disease severity again has 5 stages to the level of glomerular filtration rate and the presence of abnormalities through urinalysis. And classification is a predictor. Classification and severity, is sort of a predictor of the complications and progression, and provides a guide to the need of further investigations and follow up through nephrology referral. So I want to say thank you again for tuning in on this audio podcast, which has been about primary renal and primary care. Just again, I'll just highlight a few acknowledgements for with colleagues and collaborators who helped co-developed the slide set here. Once again, the context in here will be available on in and in between the Storm Robotics social media platforms. Thank you again for tuning in on this audio podcast, and I hope it's been helpful. Thank you.